Good afternoon. It's nice to see you again and be with you, Mary Ann. Are you all packed?
I am packed, Sarah. Thank you so much for asking. Ready to roll. How about
Yes,
you?
I am all packed and I'll be following you. I think you go out in the next couple hours. You're going to be flying to Munich, Germany,
That's today. Yeah.
on our way to the NATA annual symposium, where we will have
Yes.
3 days of international cohort and networking with our PBM people.
What does that stand for again? Network for the Advancement of Patient Blood Management, Hemostasis, and Thrombosis. I hope I got that right.
Perfect. I'm always excited when they come to our SABM conference each year. This will be my first time going to them. So
Yay.
I'm really excited about joining the global community overseas expert that we're going to talk to before we leave. So we're going to have a great discussion with Dr. Tibi. He's been active in patient blood management for 30 plus years. He's a cardiothoracic surgeon and his name appears in numerous research articles on the topic. He really is a true leader. He serves on the SABM board, and he has served as a past president. So today we're going to be talking all about his experience and PBM and cardiothoracic surgery. I think it's going to be a great discussion. Welcome to the podcast, Dr. Tibby.
Thank you.
Well, thank you very much. It's wonderful to see you two again, Sarah and Marianne. I know you will have a wonderful time in Munich. Natai is really very informative and interesting. You get to understand various trials and tribulations of people who are in patient and blood management around the world because I've learned so many things by going to Natam. So I think you'll have a great time. Unfortunately, I can't be there. I'm sure you'll have a great time. And Marianne, don't go too crazy.
No promises there.
He knows us.
Thank you so much. I know you're very busy, and we really appreciate your time today. So let's get right into it, Dr. Tibby. Let's talk about your early exposure to patient blood management. This arose from needs in the bloodless community, which is really interesting. Can you tell us about those early days and how you got started and
Of
how that
course.
influenced you?
My interest in patient blood management was really very serendipitous. I had just finished my residency. I was a new cardiothoracic surgeon in Phoenix, Arizona. One day I had a patient come to the office who needed cardiac surgery and told me she had been to 3 different cardiac surgeons who said if she would not accept blood, they would not accept to do her surgery. She came to me and pretty much in desperation, truth be told, I needed the work. I was relatively new in the community, and it was a challenge for me that I thought I would undertake. At that point, I started thinking, this is before patient blood management was even really known. Uh, this was a time when giving a blood transfusion was really only thought to be helpful, that blood was the giver of life and so forth. So there was really no concern about transfusing patients as much as they needed. At that point, I had to start thinking about, gee, what do I do to decrease the risks of needing to give a patient blood when we do open heart surgery? At that time, over 70% of patients who underwent heart surgery were getting transfusions of blood or blood products. Really, the only thing I can come up with is to hope for that the patient had enough blood stores and to be really, really careful during surgery and try to save every last drop, knowing that I might also have to tolerate lower hemoglobin in the postoperative period. Those were the 3 aspects of patient blood management at its inception. For some reason, maybe somebody put my card up in the church or something, but I started getting a lot of witnesses that came to me for bloodless surgery. After about 3 years or so, I was fortunate to be involved with someone called Richard Melseth, who I know you all know.
Yes.
Together, we were talking, and I kind of had a feeling that the patients that did not get life saving blood were actually doing better than those that were getting blood, which resulted in my first foray into reviewing charts of patients. And obviously, it was retrospective and not randomized and so forth. But in fact, it was apparent to me that that was the case. So we're talking about the mid 90s now.
Mhm.
This is when PBM, or patient blood management, really started to flourish, at least in certain circles. With the establishment of the Society for the Advancement of Blood Management, as well as other people around the country and the world, were coming to the same conclusion.
So that was 30 years ago. In the mid 90s, you're starting to understand that, oh, what I thought was life saving and best for the patient, if we can avoid it, we have better outcomes. How do cardiothoracic surgeons or surgeons in general, how do they view blood today? Do they all understand that patients do better if donor blood can be avoided, or do they still see it as a life-saving, beneficial thing to give all of their surgery patients?
So, over 3 decades worth of development, I think we're finally getting to the point where most, if not all, cardiac surgeons and surgeons in general and physicians in general understand that there are risks to giving blood. And yes, there are infectious risks such as HIV, and that's a whole story of itself, how HIV brought patient blood management to the forefront as well. But infectious risks are really quite low. We realize, though, that every unit of blood that we give causes an immunological reaction. And that basically, blood is an organ, just like the liver, the kidney, the pancreas, but it's a liquid organ. One of the things that really brings it to mind is that when somebody has kidney failure or liver failure or heart failure, our first course of action is not a transplant because of the problems with a transplant and effects on the whole homeostasis of the body. And therefore, transfusion shouldn't be our first response to a low hemoglobin, especially since blood is the really only organ that can completely regenerate itself.
Yes. Yeah.
That's a really great perspective. Yeah. Thank
So,
you.
to answer your question as far as how well known it is, I think that physicians and surgeons, and especially cardiac surgeons, are now becoming very aware, not only because of the education piece, but also because regulatory societies, societies like the Society of Thoracic Surgery, hospitals, and everyone else is looking at the utilization of blood, knowing the cost as well as the ramifications in the success and health of a patient.
So when you were telling your story of the bloodless care patient, I was thinking, number one, congratulations to her. She must have been so desperate. She was willing to take a new doctor out of
Yeah,
residency
somebody
and put her life
somebody who had
in
no
his
track
hands.
record.
Right. So, like, kudos to her. I was thinking, okay, so he has good surgical technique that he has to focus on. He has hope that she has enough hemoglobin to get her through this surgery. And if he's a religious man, he's got prayer. That's about the tools that he
Yeah.
has. What tools have been developed, or what tools do you have today that you didn't have then?
So, with the development of patient blood management as well as technological developments, we have so much available to us that will help us in performing surgery in a relatively bloodless fashion. And it encompasses the entire perioperative realm. So preoperatively, not only do we hope that they have enough blood stores, but we diligently look for patients who are not only anemic, but also possibly iron deficient, but non-anemic. In every patient that I see, and obviously this is easier in elective patients than emergency patients, but every patient that I see in the office after they see me and they accept to undergo surgery, at that point we get blood studies, iron studies to see if they are anemic or iron deficient. If they are, we now have an anemia clinic where a patient not only is educated on what we're doing and why we're doing it, but they're able to get their iron stores repleted, their hemoglobin repleted, etc. Another important preoperative step is the fact that many patients now are on blood thinners of one sort or another. And not only do we know this, but we have the ability to reverse patients who are possibly prone to a coagulopathy secondary to their drug intakes. Intraoperatively, there's a ton of things that we do. Specialized circuits, mini circuits, so taking out as little blood as possible that goes into the heart-lung machine, ways of assessing a patient's own coagulation process, something called viscoelastic testing. We have drugs such antifibrinolytic drugs which prevent the breakdown of blood clots. We have what we call topical hemostatic agents that help us in achieving coagulation in areas that are prone to bleeding. Once again, postoperatively, we continue the aggressive replacement of iron and use of a drug that may stimulate the bone marrow to rapidly replete the blood stores. We know that tolerating moderate low hemoglobins is better than repleting it with blood, so i.e. restrictive versus a liberal transfusion strategy, as well as many other things. So that's a whole litany of things that doesn't cover everything.
Let me just stop you right there. I just want to go back to the beginning. Back when you started, the norm was set up 4 units of packed red blood cells and 2 units of platelets, or maybe even more than that. Now you are thinking from a non-transfusion default, and it has nothing to do with witness or not. This is for all patients? All patients. You're looking, yeah, that's awesome.
In fact, going back to when I was talking to you in the early days with Richard Melseth, that was our mantra. If our Jehovah Witness patients are doing, our bloodless patients are doing better than our none, why don't we do this for everybody? That's how we treat it today. Every patient gets the same treatment, with the sole exception in rare circumstances where a transfusion may be necessary.
Sure, absolutely. Some of those big tools that you mentioned, can you kind of educate us to how those tools help you? I'm going to start out with viscoelastic testing. How does that help you? It's a test, correct?
Right.
Okay. Can you explain how that works?
Yeah. So viscoelastic testing has been around actually for over 20 years. I started using it a little over 20 years ago. Viscoelastic testing, it's basically a test which assesses the coagulation of blood and what factors that may or may not be in blood to affect that coagulation system. Uh, Before viscoelastic testing, and still today, we can check blood by what's called a pro-time or prothrombin time, PT-PTT. Unfortunately, those tests take a while to understand, so about an hour. And if you have an actively bleeding patient, you might be behind the 8 ball by the time you get the test back. Viscoelastic testing is more or less a point of care system, meaning you can do it very quickly, oftentimes at the bedside or in the operating room. Within 10 minutes or so, you start getting an idea of if the blood is normally clotting or if it's abnormally clotting. And if it's abnormally clotting, why is it abnormally clotting? Do you need clotting factors? Do you need fibrinogen? Do you need platelets? Are the platelets working, etc.? So that can pinpoint what is needed in a bleeding patient. In the past, without viscoelastic testing, while you're waiting for the results, you would basically throw the kitchen sinks at the patient, meaning you would give them blood if they needed it, but you would give them platelets, you would give them cryoprecipitate, you would give them fresh frozen plasma. All of those things are blood products which also have possible risks that you're throwing at them when you're not actually certain of what is needed. So going back 20 years ago, viscoelastic testing really wasn't all that accurate. In fact, I stopped using viscoelastic testing for a while because it wasn't giving me the information. Over the last decade or so, it's become extremely accurate. There are multiple machines that are on the market that can test the blood. In fact, the Society of Thoracic Surgery clinical guidelines to patient blood management suggests that point of care testing with viscoelastic testing is a class 1 recommendation, meaning it is the standard of care. Yet, not all programs have viscoelastic testing, and even some programs who have viscoelastic testing don't use it to its fullest extent.
So I'm kind of taking away a couple points. Number one, if I'm a patient and I'm going in for heart surgery, I should ask if they use viscoelastic testing because that will give me an idea of if I'm bleeding, if they're going to throw the kitchen sink at me, or if they're only going to give me what I really truly need and lack.
And if you ask the surgeon if they have viscoelastic testing, they're going to be very careful on what they tell you.
Very well, they know you're an educated patient.
Exactly.
The other thing is, so this is a blood sample, right, that is analyzed. Does it change throughout the surgery? Like if you check a viscoelastic test at the beginning of surgery, will the patient have the same clotting status and things that it needs to make a clot 3 or 4 hours in? And if not, if that changes, what changes it?
So everybody's clotting status is actually a little different. We test it before, during, and after surgery. When you're having heart surgery under cardiopulmonary bypass, that's the machine that circulates the blood and takes over the function of your heart and lungs. Obviously, the patient needs to be heparinized, meaning we give large doses of heparin, which is an anticoagulant, so there's no clotting in the machine. So we do a test while the patient is on cardiopulmonary bypass, which will show that the blood is not clotting, and it will show that the reason the blood is not clotting is because there's heparin in there. Once we've reversed the heparin with a drug called protamine, we then do a third viscoelastic test. At that point, we can tell if there are lack of various clotting factors or fibrinogen or the platelets aren't working. At that point, we can decide how to treat the patient. It also sometimes is important to look at the trend of the various parameters that you get from viscoelastic testing. So yes, it does change. It does change all the time. And that's the problem, is it changes all the time.
Gotcha.
Fascinating. Wow. Yeah, thank you for explaining that.
Let's move on to topical hemostatics. What are they? How do you use them? And again, is this something that everyone's using?
How do people that decline blood view these topical hemostatics?
Whenever we take a patient who has a religious or belief that they do not want to accept blood, it's not just a matter of, okay, we won't give you blood. You have to understand and discuss with a patient, bring them to the center of the discussion about particularly what blood and or blood products and or products that might utilize various blood factors they are willing to accept or not accept. Not only that, you have to look at when blood is taken out of the system, such as something called ANH, which is where we take blood out of the patient right before surgery to give the blood back. And you say, well, what is that? What does that accomplish? Well, when we take the blood out of the patient, that blood, that particular couple of units of blood doesn't go through the cardiopulmonary bypass system, which can change the coagulation milieu of the blood. And then we're giving them back their own autologous whole blood, which has active factors, active platelets, and so forth and so on. So not only is it you have to talk to the patient about blood products, but also products that may use blood sources, as well as how you're going to uh, take care of their own blood during the operation. And back to Sarah, back to your question about topical hemostatic agents. Topical hemostatic agents are agents which help stop bleeding. There are probably 40 or 50 agents out there on the market, and some of them work differently than others. Some of them are way more expensive than others. Some of them have different modes of application. The important thing is that you use the right product for the right situation. So We can break these up into agents which are passive, agents which are active, and agents which are a combination, as well as agents whose goal is to seal tissue, called sealants. So, very briefly, passive agents, you have to understand how blood clots. Blood clots, as soon as there's an injury, there's fibrin that attaches, and then the platelets stick to that, and that's called the primary clot. Then there's a secondary clot, which stabilizes the clot. Otherwise, if you don't have that secondary output, there will occur what's called fibrinolysis, which breaks down the fibers. People might say, well, why would the body clot and then break it down? Because sometimes you form clots in areas that you don't want, whether it be a vein or an artery, and that's the body's defense for blood clotting. I heard, and I can't remember exactly who said it, but it's a quote that the blood affects living by making it not bleed and not clot. So it's like on a seesaw. You got to keep it stabilized. So passive agents are those agents which do not have active factors, and therefore it just provides the scaffolding for blood clot to form. In a passive agent, you have to have an intact coagulation system. Now, many patients during and after surgery, their coagulation system is not intact. In those situations, you need an active agent, and those are and that's usually something that has thrombin in it, which helps blood to clot. So you want to use those agents in patients who have not an intact coagulation system. Like I said, there's combination of passive and active agents together, which are not only the most effective, but the most expensive. Those are colloquially called clot in a box. Then there's the sealant. Now, a sealant is not necessarily for bleeding, but it's for prevention of bleeding. So when we repair an aorta, so that's a high pressure aorta, and you repair it and it looks good and there's no bleeding, but maybe later on, if the blood pressure goes up, it will cause some bleeding. So that you put a sealant, and it's almost like a plastic covering over a tissue. There are different types of bleeding. There's raw surface bleeding, which requires like a broad application. So there are ways to spray these agents on. There's particular bleeding where it's just, let's say, needle holes, where there's an other agent that kind of stabilizes the needle holes. So the important thing is to know how all these agents work and to use the right agent, the right product for the right situation. Unfortunately, I've seen too many times when someone might have just a favorite product for whatever reason and is using it in all situations. And sometimes it'll work and sometimes it won't. And if it doesn't work, not only is it not good, but it's also an expense that's not warranted.
If I followed you correctly, you first have to know, is the coagulation system intact? So you probably can rely a little bit on your viscoelastic testing to help you choose what type of hemostatic agent to use on the patient. Is that correct?
Yes and no. In patients who have undergone cardiopulmonary bypass, usually there is some change in the coagulation profile. Usually, though, we're using these agents even before we come off of
Okay.
cardiopulmonary bypass.
So you know that it's not intact just because of where they're at the surgery.
Correct.
Okay.
Correct.
Gotcha.
But that's really for the reason for passive or active. A passive agent won't work if there's a coagulation defect.
Wow. Really great education for me as well as a patient. I hope everyone's able to follow and understand that.
I was just going to ask about cell salvage too. Cell salvage has got to be an integral part of this game here.
Absolutely. Cell salvage is also a class 1 recommendation, meaning it is a standard of care. It's used in every open heart patient that we do. It's the ability to get the blood that's lost, clean it, and reinfuse it back to the patient. In fact, what we do actually is to take the blood and actually put it through dialysis filter and be able to give it back to the patient in that way that they still maintain the coagulation factor, more coagulation factor and more platelets than just simply washing the cells.
So when Sarah's making her appointment for cardiovascular surgery, she's going to be asking, do you do cell salvage?
Yeah, exactly. I have my list. So all of the tools that you have now, which of those do you think is your biggest game changer? What would you say is your best tool?
Let me preface this that patient blood management is very easy to understand, but difficult to do because there are so many parts that it requires the patient to be taken care of in PBM ways before, during, and after a procedure. I don't think that there's not one tool that will significantly decrease the need for blood other than one, and that is education. Education on patient blood management is the most important tool. Let me say one thing that these past 3 decades have, as you all know, it's been an upward battle to get people involved in patient blood management because it was so ingrained in the past that blood is harmless. Let's say a patient is bleeding in the intensive care unit. Surgeon comes out, your grandfather's doing fine. He's just going to get a couple of units of blood. Or would you rather hear your grandfather's doing just fine, but there's some bleeding, and we're going to take him back to surgery to make sure that there's nothing that we can do for the bleeding other than treat the coagulopathy. So in the first instance, most lay people, I think, would believe, what granddad just had heart surgery, it's normal that he's getting blood. Whereas in the second incident, patient families or patients even may think, well, they missed something or something's not right, or, it appears to be a much greater risk when in fact, treating a bleeding patient, obviously both scenarios, the patient's bleeding, otherwise you wouldn't give him blood, but treating a bleeding patient should be first and foremost to assess that there is nothing that is surgically bleeding in light of a normal coagulation system. Studies have shown that early take back is what we call it, an early take back or second look operation, which sometimes sounds better, is a better treatment to bleeding patients, non-coagulopathic bleeding patients, than simply giving blood. Because with every unit of blood, you are causing an immunological reaction that has been shown to increase morbidity and mortality, morbidity such as renal failure, pulmonary failure, cardiac failure, as well as just giving blood in a patient that's bleeding. There's a syndrome called retained blood syndrome. So let's say finally the bleeding stops, but there's 2 or 3 units in the pericardial sac. That increases the inflammation, increases risks of atrial fibrillation or irregular heart rate after surgery. Worst case scenario is that the bleeding continues to cause what we call cardiac tamponade, where the blood is pressing on the heart. These patients often are emergent situations. If they're not treated rapidly, it can cause their immediate demise.
I'm glad that you brought out that point because before you stated it, if my loved one was having surgery and they said, your father is doing fine, he's just bleeding, we're going to give him a little blood, versus your father's doing fine, he's doing a little bleeding, we're going to take him back and just make sure there isn't more we could do. I would be more afraid of the return to surgery, or I would think, oh, maybe they missed something. But it is true that we learn in patient blood management that when someone's bleeding, the best opportunity for the patient is that you stop the bleeding. You intervene medically. You don't just feed them blood. So it does make sense to me. And I would rather you take my father or loved one back and have a look, see.
And there are recent studies that show just that patients that are bleeding do better in the long run with an early take back versus delayed or no take back. In fact, cardiac surgeons are followed by the Society of Cardiothoracic Surgery for various complications, whether it be infections or atrial fibrillation. Obviously, there has to be a certain amount of complications with any surgery, but they follow it. But what they have followed in the past is the number of takebacks, whereas they didn't follow how much blood you gave. And that is changing now.
And this is why education, as you said, is an enormously important tool. we've been taught, and we're still taught, blood is life-saving all the time, no matter what. And that's, really kind of a fallacy. And then also, this knee-jerk reaction, we're taught, oh, they're bleeding, give blood.
Yeah.
There's very good reasons not to, very
And to
often.
your point, Marianne, too, it's not just education to the surgeons, because
It's
as Dr. Tibby has brought out, PBM has to be applied in all aspects of care.
right,
So any
right.
clinical person that touches that patient really needs education in patient blood management.
And another thing that I think is important is, for whatever reason, and now I'm speaking to my own specialty, for whatever reason, patient blood man, when you go to the SABM, when you go to NATA, many of the people there are pathologists, hematologists, anesthesiologists, intensivists, etc. Unfortunately, there aren't that many cardiac surgeons or surgeons per se, more so these days. But when we look at patient blood management, that it involves the entire patient before, during, and after surgery, there's only one person who takes care of that patient before and during after surgery, and that's the surgeon. Unfortunately, the anesthesiologist will see a patient, at least in the US, it's different. I learned that at Nata, is that the anesthesiologists are much more involved in preoperative assessment and preparation for surgery. But here, at least in in my institution, an anesthesiologist will see the patient 30 minutes before the case. If a patient is anemic or iron deficient, there's nothing the anesthesiologist can do. During surgery, oftentimes it's the anesthesiologist who's deciding whether to give blood or not in my operating room. And after surgery, the intensivists are often taking care of hospitalists. And once the patient's bled, there's not much they can do if they're at critical levels. So it behooves the surgeon to be involved in patient blood management, because they're the only ones that can affect perioperative blood management.
Before we wrap up this discussion, at the beginning of our conversation, you said that 30 years ago, 70% of patients who were undergoing cardiothoracic surgery would have a blood transfusion. Do you know what the number is today?
Right now, the average number is between 30 to 40%. In our institution, it's in the teens for primary cabbage
That's
Okay.
and
awesome.
in the low 20s
That's
for
awesome.
all comers.
This month, May, is Bloodless Medicine and Surgery Month. It's May 16th. So we always
Yeah.
like to, give a little shout out to the bloodless care community and thank them for
Hmm.
their advocacy, because it has led to patient blood management and a higher standard of care for all patients. Thank you for letting us practice patient blood management on you so that we get it right.
And it's people like you and the nurses and the physicians and the administration that
Hmm.
really needs to get involved, because administration's always looking to cut costs. And oftentimes cutting costs comes along with decreasing services or using something that's not quite expensive. There are very few things in medicine that decreases costs and improve qualities, and patient blood management typifies that.
Amen. Yeah. Yeah, absolutely.
Well, we really appreciate the conversation and your time, Dr. Tibby. People that we have on our platform, we highly regard and highly respect. We're very careful about who we choose to bring onto our platform and teach patient blood management. We like to give you the opportunity, everything we've discussed or any other point that you'd like our audience to know, please give us your takeaway.
So my takeaway is doing exactly what you all are doing, is informing the public to understand blood better. Now we're talking about blood health and maintaining that health of your blood, just like you maintain the health of your heart and your kidneys. The more that it is put out there, the better it will be for patients and their recovery.
Very
I
good.
congratulate you guys on what you're doing. I appreciate it. It's fantastic. Keep up the good work
Thank you.
and have a great time in Germany.
Yes, absolutely.
Okay, stay, not too much beer now.
All right. All right. We won't.
Okay.
Thank you so much.
You're welcome, Sarah. Thank you, Mariana. Appreciate it.